Well, welcome everybody. And thank you for joining us for part 2 of Nurses Month Door-to-Door celebration. I'm Patty Sengstack, and I'm the Senior Director for Nursing Informatics here at the Vanderbilt University School of Nursing. Hopefully you were able to join us on Monday, where Dean Norman and a group of panelists talked about key people who have guided the evolution of nursing, and about how the media and entertainment industry have misrepresented and often underutilized nurses as experts. But today we're changing our trajectory a little bit, and we're going to talk about how some of the paths for nurses can be different that they take, and they're beyond that of the traditional bedside care. And as I was thinking about this presentation, I remembered that it was about a couple of months ago, I was at the dentist, and the dental hygienist said to me, "Oh, you're a nurse informaticist." I said, "Yes." She said, "You know, I can't believe how many different places you can parlay that, the nurse. You can do so many different things." I said, "You know, you're absolutely right." So today we have a great panel that's going to talk to us with some questions about this topic. We have Dr. Nalo Hamilton. She's the Associate Professor and Breast Cancer Researcher from the University of California, Los Angeles. We have Dr. Sheridan Miyamoto, who's an Assistant Professor at the College of Nursing and Child Maltreatment Solutions Network in Pennsylvania State at the Pennsylvania State University. We have Dr. Simona Black, a retired colonel in the U.S. Army Nurse Corps and Assistant Professor at Norfolk State University. We have Dr. Julia Philippi, who is the Director of Nurse Midwifery here at the Vanderbilt University School of Nursing. And we have Dr. Komi Koku-Abi, who is the psychiatric nurse practitioner in Austin, Texas. So we're going to start out with some questions. And Nalo, I believe you are first. So question for you: how do you decide that nursing was the best path to accomplish your goals as a scientist?
Well, I came to Vanderbilt as a biochemist. I had already obtained my biochemistry PhD from Meharry Medical College, and I was doing breast cancer research. So what I needed was to better understand the clinical component, because I wanted to have a better lay of the land in the first 3 sentences in a grant that says this is the clinical application. And I selected Vanderbilt because it was the only program that was accelerated and had a women's health program. And so what attending Vanderbilt allowed me to do was meld both my research expertise with clinical expertise in the population that I had of interest. And so nursing gives me the ability to answer clinical questions. It gives me the opportunity to answer community questions, as well as help to inform my research as I do it in lab-based or bench science.
Excellent, thank you. The next question will go to Komi. As a mental health provider, what advantages have you seen in choosing nursing over medicine?
Thank you, Patty. I am a psychiatric nurse practitioner in Rock Spring here in Austin. And prior to starting my journey in nursing, I went to medical school for a year back in Togo in West Africa, where I'm from. And I think the advantage that I see in choosing nursing is twofold. On one side, it allowed me to, since the goal was to become a provider, it allowed me to do some bedside nursing, get to be in that patient advocate role before I get into the provider role. So seeing mental health patient now just seems to be so much easier to pull from a nursing background and a provider background and kind of like provide a patient-centered kind of care. The other side also is the fact that I was able to work while I was still in school, right? As a registered nurse while I was still in school. So that was added advantage of nursing, where you get to, you don't have to put everything on hold while pursuing your goal to become a provider.
I bet And if we have time later, I'd love to hear a little bit more about how busy you've been during the pandemic in your field. Have you been, give me a thumbs up if you've been super busy over the last year.
Very busy.
Yeah, I bet you have. Yeah, well, thank you. Okay, the next question is for Julia. So what sorts of doors has being a nurse midwife opened for you?
I've been amazed at where I ended up from where I started. So I went into midwifery. I wanted to care for one individual in one room at a time. Like, I was very patient focused. And then over time, I started seeing, oh, if I make these changes in my small rural community, I see these changes at the county level, and that affects our rates. And like, I can really make change in public health. And then I got interested in education. Like, you know, I can't care for everybody, so I would love to help make nurse midwives. And from there, I got really interested in research as well, because it's that different level of how can we make change for these individuals. And I don't think when I started, I would have ever realized that I, with nursing, could go into more of a community approach rather than just a patient approach, that we could, you know, make change in communities via education and making new providers, and then doing our own research. It's been fabulous. I really loved the journey.
You just continued to broaden, you know, your scope of influence, you know, throughout your career, haven't you? You know, I sort of feel the same way with informatics. You know, with you know, nurses touched so many pieces of technology, so you know, you have the ability to not just touch one life at a time, but to touch, you know, a broad audience. So, yeah, great, thank you.
Yeah.
Next question is for Simona. So you were in the military, a leader in the military. How has nursing prepared you to be an even better leader?
Yes, thank you. Thank you all for this opportunity. So being in the military, they really groom you from the very beginning, from when you come in at the bedside, and they really hone that in and drill that into you. You are a leader. So you're a leader for that patient, you're a leader for the next nurse coming up that you're mentoring and you're precepting, you're a leader on your unit. So they really prepare you all along from the very, very beginning, that leadership role in nursing. So it was no doubt that, you know, that as you grow up in the military, that you take on those increased leadership roles. So when I came to Vanderbilt, I was already in that leadership role at the board level. And really, I saw the impact that nurses had, because we were so intimate at the bedside with the patient. So we knew really, you know, clinically, you know, any changes at the administration or the policy level, how that would affect nurses and patient care on that end. And I felt it was hugely important that we had a voice to really shape those changes at the policy level. And so coming to Vanderbilt, really honing in those skills and building my street credibility as far as being able to shape those policies at the corporate level. So when I'm there with the hospital administrators and the hospital CEO, I have a voice there and credibility, because I have a clinical and I also have that administrative portion of it. So with the military, it really groomed me, because not only are you in those roles, it also gives you the opportunity and the flexibility to go back clinically. So I had that choice to also go back clinically so that I can, you know, again, re-engage that clinical aspect, so that when I go back to the leadership role, I have more information. I have that, again, that street credibility to really shape the policies at the hospital level, and just the experience of being able to do that and go back and forth and not start over again. And that's the beauty of it. Each time I go into a new organization, I'm not starting over. I'm just continuing where I left off at a different organization, you know, with at a different location, but with the same organization. So.
And all the time, just using the nursing process again and again and again.
Absolutely.
It
Absolutely.
never fails you, does it? Assess,
never.
plan, implement, evaluate. You know, I've always said that nurses, you know, when people ask me about nursing, you know, I always say it's at the hub of care delivery. It's kind of like, you know, a wagon wheel with the nurse at the hub, with every spoke that comes off of it. You know, whether it's, you know, a pharmacy, you know, the physicians, the social worker, you know, medication delivery. I mean, every aspect of care is touched by the nurse. So when you take that to your environment where you're building policy and developing policy, it is so important. So I'm so glad you have a voice at the table for that. Thank you for, you know, you're having the voice for us. All right, next question is for Sheridan. In your experience, how do you see nurses reinventing themselves while solving societal problems? That's a big one.
Big one. But I think, you know, as the other panelists have answered, we're starting to see just that nurses, there are an infinite number of career paths within nursing. And so I think, you know, we've all got this great foundational base at Vanderbilt and are able then to go in. So I started to practice in a rural community. And when you're trained in an academic medical center where there are lots and lots of resources, you know, it's really quite different than to go into a rural setting. And I worked there in primary care as a nurse practitioner for some time, and then had an opportunity to go back to an academic medical center at UC Davis and be trained to do child maltreatment evaluations. And so through that, you know, it was like, oh, I had thought I was just going to do primary care, and then have an opportunity to really deeply engage in a specialty, and one that I hadn't learned very much about at that point. And then as I did that and moved and transitioned to do that more full-time, realized, you know, kind of went back to the work in rural communities, that those specialties just don't exist, and we don't have enough nurses that are trained and enough other interdisciplinary partners that really understand what needs to be done for children that are experiencing maltreatment. And so, you know, got introduced to colleagues back in 2000 that were doing telehealth and thinking, gosh, that's a way that we can connect to rural communities and really bring this expertise there. So, you know, I found myself doing those things, loving that work, feeling like I was really connected, but like many of the others, realizing this is a bigger problem and I need some additional tools in my tool belt to, you know, break the cycle of abuse for families and think about systems that aren't working well. And so, you know, as the nurses that are out there and that are getting their first degree, even at Vanderbilt, to think about coming back when you go out in the world and you find that problem that you really can connect with. And we don't have all the answers yet. So then getting a PhD to really say, I need to be trained so that I can look at these problems differently and try and have an impact on a different level and teach the next generation of nurses and share the experience that we have. So, you know, it's the richest career pathway I can imagine, because I think I'll probably pivot again. You know, there are other things to develop for the field or do some innovation or entrepreneurial work. So it's an incredibly rich career, and I think nurses have a lot that we can offer.
Absolutely. And I was, you know, being the informatics nurse here, you mentioned it, but I was going to ask you about telehealth in your population. So you've probably seen that advancing and being used a lot more frequently than pre-pandemic. Is that true?
Yeah, you know, I think especially when we're talking about policy, and you know, that the pandemic has accelerated our ability to use it well. And I think we had a lot of lessons because we'd been using it for so long that we could share with others about how do you do this effectively, and how can we even precept nursing students through technology? Because we've been doing it with, you know, bringing a telehealth specialist to partner with a local nurse. And we now have all learned some, but I think that the policies around reimbursement and how can we cross state lines and some of the other things that really were pushed forward because of COVID will benefit how we can rethink how we deliver our care across different platforms. So it's a big win in that way. One silver lining, right?
Now you're singing my song. Yes, absolutely. Okay, so what I'd like to do next is kind of open it up a little bit more. I have a question, and I'll ask somebody to, start the responses, and then, feel free, if you want to chime in and address it as well, then we can kind of have a conversation. So the first question I have, I'm going to start with Julia. How does nursing give you opportunities and freedom to pursue other areas of practice that other vocations don't?
Yeah, I think we've all hit on this a little bit, that nursing gives you the ability to grow. If you see a problem, you're allowed to grow into that space and make that change or learn this new skill set. And as somebody who really enjoys learning things, it's really nice to be in nursing, because no one ever says, oh, you learn this thing, your career will never change. It's not that way at all. It's constantly changing, and there's all these people that come in. And so one day to the next is not the same. And I really appreciate that ability to keep growing and learning, and not sitting on our laurels and not saying, this is the way we've always done things, this is the way we're going to keep doing things, but innovate. Yeah.
Mm-hmm. Other thoughts?
To that point, definitely in the military, but I see this even more so now. Early on in my career, nurses were really, I shouldn't say relegated, but we were primarily in the hospital setting and in the clinical setting as leaders. And then the word got out that we were that good. Our nursing process really gave us that ability to really tackle those problems. So now you started to see nurses in areas outside of nursing. And then we became so like a hot commodity where they wanted us in the command roles, and they wanted us here because, to solve this problem. And it really, and now as I retired, I see nurses in so many different roles, to where we had our first Surgeon General woman ever in history. And she was our corps chief. So really I see the growth of really the ability, people really recognizing the ability of nurses and the value that we bring to any situation. And yeah, we're just, I should say our skills are invaluable, and we should never underestimate that.
Agreed. I think, I think we need t-shirts that say, if you want to make it happen, give it to the nurses to do. Did others have some thoughts on this?
Well,
Yeah.
I think that also nursing gives you entree into circles people didn't think you could get into. And so, as Simona talked about, you're seeing where you blossom and you have roles of leadership, but also there is clinical persuasion you now have as a nurse. So when you come in and there's a problem, and you can say, well, have you thought about this? Have you gone there? And now you have a conversation with your colleagues who, your physician colleagues, your other research colleagues, who are like, wait a minute, we hadn't even thought about attacking that problem that way. And so it gives it a fuller conversation when you're dealing with that. I know that in my research, I am working with oncologists as well as surgeons. And so one thing nursing has helped me do is to think of a process from the time the patient hits the door till the end of my trial. So I can actually think of the patient needs as well as my the needs of my staff, how that can be implemented, to what I'm trying to do with my therapy. And that's something I would not have been able to do without nursing, because nursing is very patient focused and looking at the whole patient. I wouldn't have been able to think about that without my nursing background.
Yeah, so true. All right, let me go on to the next question. And this one is for Sheridan to start us out on. We know nurses do a lot of what we call workarounds that turn out to be really wonderful innovation. So how do nurses innovate? Have you seen this happening? What's your experience with that?
Yeah, so we've talked a little bit about the benefits of being in academia or being in academic settings, and so I think nurses, always, as you say, always are coming up with solutions. We know the answers, but often nurses aren't thinking of that they're in a position to do that, and so for me, I found some things that I think are needed in the field, tools that I might need that didn't exist. And an academic setting that really is promoting invention and entrepreneurship, I think is the ideal place for nurses to get some business, be paired with some business partners or get some business training, do, kind of a kickstart, quick fellowship around entrepreneurship. And I think for me, it changes the way that I think about problems now, right? There's a different mindset around kind of business thinking. And I think for all of the good ideas or the work that we're doing clinically, it's really important to be thinking about how do we make sure the things that we do can be sustained. And so some of that business thinking, even though we like to think, well, we just want to provide the best care and would like to not think about how, whether how we make that a business, put a business lens on it. But if we don't, some of the good things we do aren't sustained. So I think the innovation pieces are finding good partnerships. A lot of academic schools of nursing are really interested in this. And so I would just encourage nurses to start asking about those pathways within school when you have a good idea, because those centers exist and they're immensely helpful.
Yeah, nurses don't give away your intellectual capital, right? You've got a lot of great ideas. Don't give them away. We have here at Vanderbilt, we have in our science and engineering building, we have a place called the Wondery, which is kind of like an innovation incubator where you could take your ideas and they'll work with you, similar to what you were just mentioning, Sheridan. Others experience with innovation? Other thoughts on how nurses innovate? Comey, I see you came off mute.
At in the field that I work in, psychiatry, the hospital where I am, quality improvement project hasn't been something that they have been focusing on until I started working there. And I introduced that concept to them. Fortunately, it was received very well, and we started doing some quality improvement project. Identifying problem areas where we can improve on, especially when it comes to polypharmacy and deprescribing, and kind of implementing those processes has been really successful. And the organization seemed to be very pleased by that kind of innovation that was brought to the table.
Sometimes you hear the word innovation and you think it's like some glitzy, glamorous, really far out crazy thing with bells and whistles. But the reality is that sometimes the innovations that are things like that you mentioned are some of the things that are absolutely the most effective. That's great. Thank you for sharing that. Let's see. Let me go on to the next question. And think, Nalo, this is one for you to start us out. How does your nursing background make you more effective and stronger in your current pursuits?
I think it's the commitment behind the nursing process, because everything circles back to the patient. How do I improve the patient's care? How do I improve outcomes? I have to say that when I am looking at my therapy at the bench, I'm always thinking about, okay, will the patient actually be able to take it at this dose at this time? Is this feasible? What is the education I need to not only give the patient, but my clinical colleagues? So it helps me to keep this in mind as I'm doing something. I have to admit that before coming to Vanderbilt, I thought of research as just that, a standalone research opportunity. The hypothesis, test it, come out with it. I didn't think about the ramifications. I am much more well-rounded in thinking about my process. The nursing process has helped me make sure that, okay, if you're going to do this, but how does it track back to this? Is this something that you can actually implement with a patient? Is it something that you can even implement into a system or a process? So I think it drives my commitment, because if I see something that I don't think is going to work when I've thought through it in that format, I go back to the drawing board and say, okay, how do we improve it? And sometimes my colleagues are like, wait a minute, we wouldn't have thought about that. Well, I've already had 3 iterations before I've shared it with you, because I want to make sure my patient population will do it. I can do the education. And yes, there's going to be the science behind to show that this intervention is actually efficacious. So I think it keeps my mind looking and searching to say, is this the best way for the patient, for the system, and for the community? That's always going around in my head.
Yeah, I totally agree. I think that, the graduate education takes your practice up to that next level where you can really do those things. And my experience is you don't know it until you actually, finish the program and you think, I thought I was really smart before, but now I'm even smarter. All right, I'm looking at our time, so I'm going to do just one more question. And this one, Comey, I'm going to have you start us out. What do you say to someone trying to choose or change their career path and to encourage them to look at nursing?
I guess the evidence is here tonight, right? Multiple areas of expertise, people you can pretty much do whatever you want with a nursing degree. I'll speak a little bit to the provider side, if the goal is to become a provider, I think bearing from state legislation, you pretty much can do, the job of a physician, because your education prepare you for that area where you have been educated in to be fully competent and, do the job. So, you can be an administrator, researcher, yeah, the opportunities are boundless.
Lots of choices. Other thoughts? What would you tell someone thinking about, I don't know what I want to be when I grow up?
This has happened in my household a lot because I have teenage children who bring friends in, and they tell me what they want to do. And I'm like, actually, have you thought about nursing? Nursing is all of those things. Would you like to think about that? And one of them has applied to nursing school and will be starting in the fall. So I'm super proud of her. She actually came into our sim lab as well. And I think that may have pushed her over the edge. So yeah, it comes up in conversation for me.
Others?
I would just also say, I think, nurses are such great communicators. I don't know if that's those of us that are drawn to it. But, as our teenagers are looking for meaningful jobs, there's just tremendous, you cannot beat nursing for doing some meaningful work, addressing societal problems, no matter what you do in this field, whether you're touching, interacting with a patient one-on-one, doing other things related to improving healthcare for populations, there just isn't anything better about being able to do something that we love. We get a lot back for it, and it's not just all us giving. It's just incredibly rich in both directions. But the importance of doing something meaningful, I think, is something that a lot of people spend time looking for and can't find. But I think, this is evidence that people have found it.
Agree. And Simona, let you make the last comment for us.
I think everyone has touched it. Nurses I'm here in the DC area, so they're at the legislative level. They're making changes in the laws. They are at the corporate level. They're consultants. I see nurses in every single role. And to Sheridan's point, as far as don't give away, I'm going back to the innovation. Don't give away your creative abilities. Nurses are so creative. And I listened to a podcast, Nursepreneurs, and they talk about really, all the different things and the problems that we saw and we fixed and we did it. So nurses can across the board do pretty much anything that they want to do. And we're so versatile, and that's the reason why we're in such high demand. So I'm very proud of what we do, and I definitely mentor and encourage all the young, and even maybe the not so young on their second career, more mature, to go and look into nursing. Mm-hmm.
Yeah, I agree. Thank you so much. Nurses make it happen. So I know that there were some questions that came through for this segment. I know we probably are not going to be able to get to them, but hopefully we'll be able to address them maybe in a panel in the future. So thank you all very much. I appreciate all of you joining us today and taking your time to be on this panel with us, and those of you out there listening. We're going to pause for about 30 seconds, and then we're going to begin the next panel on full practice authority. Thank you.
Hello, my name is Ruth Kleinpel, and I'm currently the Associate Dean for Clinical Scholarship at Vanderbilt University School of Nursing, and it's my pleasure to be moderating the second portion of our panel this evening. And we're going to be addressing what COVID-19 taught us about full practice authority for advanced practice nurses, including nurse practitioners. And we have a distinguished panel. We have Marilyn Dubree, who's the Executive Chief Nursing Officer at Vanderbilt University Medical Center. We have the Reverend Michael Huggins, who's the Associate Professor and Primary Care Adult Gerontology Nurse Practitioner Program Lead at Seattle University School of Nursing. And we have LaTonya Trotter, who is an Assistant Professor of Sociology at Vanderbilt University, and author of the book that was published last year entitled More Than Medicine, Nurse Practitioners and the Problems They Solve for Patients, Healthcare Organizations, and the State. And Dr. Trotter actually spent time, over 200 hours, observing nurse practitioners in their educational program, and then 1 year volunteering and 17 months of field work with nurse practitioners at an elder care facility. So we're delighted to have her perspective with us today as well. So we all certainly can relate that the impact of the COVID-19 pandemic certainly positioned nurses in the field in all areas within the media and within the lay public. And so it really provided an opportunity to showcase the role of advanced practice nurses, including nurse practitioners. And some states, in response to the pandemic, issued executive orders. In fact, there were 8 states that issued orders to have full practice authority for nurse practitioners. Prior to the pandemic, there were 23 states, including the District of Columbia, that only offered full practice authority. And so based on the pandemic, 8 states issued temporary full practice authority, and then 14 issued temporary waiver of select practice restrictions. Now, we don't know if those 8 states will continue to have full practice authority, but certainly both of those measures were beneficial for nurse practitioners and advanced practice providers. So Marilyn, we'll start with you. What was the positive impact of Tennessee having waiver of some of the select practice restrictions in the Vanderbilt health system?
Thank you, Ruth, and it's good to be on the panel this afternoon. And I'd just like to add that some of the obvious things that happened during the pandemic were the exposure of our health system to the incredible competence and talent of our advanced practice registered nurses. And I never underestimate that. It's one of those things that's really priceless. Clearly, we had additional flexibility. It created more access for individuals who wanted to see us, not only being seen in our hospitals, we were scaling the work that everyone was doing, but also in walk-in clinics and other things. Tactically, it relieved hours of chart review that would hold up the care and things that needed to be done by our nurse practitioners and the individuals that were to be supervising them. So being one of the states that has a very restricted practice authority, we found a lot of liberation. And I think the other thing I would add, particularly for Vanderbilt, that I noticed, we placed in much of the work, not just clinical work, but the leadership work, the project management work, the innovation, the creativity that needed to be put into play for our pandemic patients and our workforce. We placed our nurse practitioners in those leadership positions. And, and that's largely because they are talented, creative, innovative folk that are really, really smart about system issues, not just clinical practice. So I think we always think about clinical practice for full practice authority is so important, so necessary. We'll all talk about that a lot this afternoon. But I think the talent is underestimated sometimes in this particular part of our population.
Great, thanks for sharing that. Now, Mike, Washington has had full practice authority since 2005, and that's been different for prescriptive authority, but certainly you've had those experiences. If you could share some of that with us.
Yes, actually, nurse practitioners in Washington state have been able to prescribe legend drugs since 1979. So that's quite a few decades ago. In '82, Schedule 5 was added to that. Now, this is in the setting of a joint practice agreement with a physician. In 2000, Schedules 2 through 4 were added. And shortly after that, in 2005, the joint practice agreement was eliminated. So we do have, for most of us, and I think in the state of Washington, the latest research that I saw out of the University of Washington was around 92% of nurse practitioners in the state of Washington have DEA numbers. And some of the ones that don't are often using an institutional DEA number to prescribe. So it's had a great effect on opening up our ability to meet our patients' needs. On the other hand, we would never have gotten here if it weren't for community organizations and citizen organizations, citizen representative groups who were solidly supportive of advanced practice in their areas. And most people will think of Washington State as being Seattle or Tacoma or Spokane. And in that, we're like Kentucky, 3 major centers, but the state itself is very rural. So a lot of nurse practitioners are in the rural areas, but without that full practice authority and prescriptive ability, they had to refer their patients to a physician. And that meant a second visit, perhaps a second copay, and a lot more inconvenience and safety issues with patients. So that's been our journey. And currently, I prescribe all legend drugs and Schedules 2 through 5 without obstacles. And most of my colleagues do the same.
Thanks for sharing that, and your point about, really having the support of patients and consumers to advocate for full practice authority is something to consider as well. LaTanya, you said in your book that the American system is very patchworked. How is that and potentially detrimental to patient care?
Well, thank you, Ruth. I think, partly to answer that question, I really want to dovetail on the comments that Marilyn and Mike have already made, in part by really thinking about the ways in which the pandemic, which is sort of what we're sort of talking through, isn't the first time that the American healthcare system has encountered a crisis. It's just that the pandemic has been a fast-moving crisis, but we've been here before, and part of the before that we've been through is really sort of thinking about the sort of rising unmet needs that we have in the American healthcare system. That was, again, the crisis that opened the door for the original nurse practitioners who began practicing in the 1960s. But I think, one of the things that we often don't talk about as we're sort of thinking about the ways in which NPs have sort of been able to sort of step into the breach into these unmet needs is really thinking about the kinds of problems that haven't been solved, right? And, because these unmet needs were not really a product of a lack of nurse practitioners, right? They were a product of sort of institutional and structural issues, right? Why do we have so many patients who don't have access to an insurer? Why do we have so many patients who even have access to care, but it's sort of piecemeal and it's fragmented? And I think part of it really points to the root of the problem, which actually continues to not be addressed. Which is that we have a privatized system that essentially creates fragmentation, right? So we often use words like fragmentation or sort of piecemeal system, and we talk about it as an error, right, of the system, but it's not an error, right? It's a feature of the system, right? When you have a system that is organized around this piece and this piece and this piece, all trying to make their piece of the pie, you have, right, built into that system, a kind of fragmentation. And I think really in order to sort of think about how we're going to address that fundamental problem, we really have to think a little bit more deeply about how we organize, pay, and structure that care. And really, I think, the nurse practitioner as a sort of wide population of providers can be a piece of rethinking that fragmentation, because as we've been having this conversation about the ways in which full practice authority happens in one place but not another, right? Thinking about, as Mike described very, very well, the kinds of hurdles that patients face when they are trying to see a healthcare provider who doesn't have full practice authority, right? That has nothing to do with quality of care. That has nothing to do with patient safety. It really has to do with other kinds of problems having to do with the profit motive that really is sort of embedded into our healthcare system.
Thanks for sharing some of that. And so maybe the answer is that we should have a national full practice authority. Mike, are advanced practitioners and nurse practitioners in Washington truly free to practice fully?
Before I answer that question, let me just comment that we do have a national plan, and it's with the Veterans Administration Authority, where all nurse practitioners have full scope of practice. So, and I think we are going to pay closer attention to that, especially in Washington State, where we have so many veterans that have retired here and are living here and receiving their care at the VA. Incidentally, I want to put a plug in for Vandy because I felt I was extraordinarily well prepared as a geriatric nurse practitioner or gerontological. And I'm really excited because the VA preferentially hires adult gero NPs. And I love working with that population. And they make their voice heard, they vote, and they're a powerful bloc. But what we've seen in my employer in Pacific Northwest, there are very few private practices left that are not associated or allied with major healthcare systems. And they do that for economies of scale. And that includes some practices that were previously owned by nurse practitioners. And one of them is a friend of mine up in Marysville, who to survive had to align her practice with a large healthcare organization. But in my case in practice, very often what I find is I'll have a full day of practice and I'll go in and I'll find that half of my day is going to be spent answering documentation and reading labs and interpreting them for another physician. And I cannot see patients during that morning or that afternoon that's dedicated to that. And within the structure itself, what I find is there is an unwritten rule that only simple patients will be seen by a nurse practitioner. And the more complex patients will automatically go to a physician. And that speaks to a systemic understanding, exactly like as LaTanya was referring to. That's a feature of the system in which I operate. But we've also had we've had psychiatric nurse practitioners in Washington State, for example, have had privileges at hospitals for admitting and treating patient hospitals. They've had that for years. And so there are restrictions even in the state where we have full practice authority, no collaborative practice agreement necessary. If we're not self-employed, we're under restrictive umbrellas, I would say most of the time.
Thanks for highlighting that. And that really is something that I think the average advanced practitioners doesn't realize, that full practice authority does not mean that you're not going to have practice restrictions placed upon you by a healthcare system or an employer. So those are additional barriers as well. LaTanya, what other restrictions have you seen in your work?
Well, it's really interesting because it's actually hard to catalog. When I really began doing my work, I thought, oh, all it really will take is sort of figuring out what the sort of state by state regulations are. But all you have to do is speak with a newly graduated nurse practitioner who's sort of on the job market and trying to figure out where to work, or talk to any nurse practitioner who has worked in more than one place, that there's tremendous amount of variation that really has nothing to do, or maybe not as much to do as you might think with the actual state practice environment. And so, as Mike noted, there are often organizational policies that both impinge, or in the case of the VA, right, sort of open doors to the scope of practice that an NP has. I think that this fight is largely over, but you never know when it could begin again, which is that, throughout the 90s, there were battles with insurance companies, right? So you had, a nurse practitioner who had the authority, full practice authority, but the insurance company didn't allow the nurse practitioner to sort of bill independently. And I think, I don't think that that's true today, but I think the lesson is when you put those kinds of decisions within the hands of organizations, organizations can always make whatever kind of decision they want to make. And so the battles may not ever be over as long as you have the power to make those decisions situated inside organizations that have their own reasons for making a decision. It doesn't even necessarily have to be a nefarious reason. It's just that they have, right, their own motivations for thinking about how they go about organizing their work, how they go about organizing their providers. And so I think, the difficulty, I think, is having business imperatives essentially structure decisions that are supposed to be about patient care, as well as political decisions that seem to be embedded in these kinds of conversations.
Yeah, you bring up some important considerations as well, as we move forward in terms of the post-COVID area for advanced practice. And Marilyn, how do you see systemic hurdles for advanced practice registered nurses impacting patient care?
Well, I really agree with Mike and LaTonya's comments, and I would add to LaTonya's last comment that, organizations can choose to do things that are more restrictive than what the state or the federal government say. It's their, they're in private business, it's their prerogative. And sometimes for safety or for financial reasons or other things, they might do that. One of the things that I think is an interesting variation in the financial piece is that an insurance company might agree to pay for a nurse practitioner to do X or Y in one state or another, but it could be that the organization or the practice would make more if clinician Z, a physician, for example, does that. And they may decide we want to do a good thing and a right thing for patients, but we want to make the most optimal amount of money. Again, not a nefarious reason. It's a business decision, but it limits systemically the ability for people to do what they're really educated and trained to do quite well. And so I think we see that there are many hurdles to what people can do to work optimally. I think the biggest outcome of these hurdles is really creating access. The ability, whether it's in a rural community or an urban setting, underserved or otherwise, to really, really excellent clinical care is really what the outcome is when this occurs, because you have to really sort that out. For example, if you're seeing patients in a health system that are in different states, then are you licensed for that? Are you aware of the prescribing restrictions or liberation in one state or another? And as we see more patients and the electronic health record is available to us, we're able to do that. Telehealth has let us do that. As that some of those things are liberated, what is the practice? I mean, those of us that oversee that, what are the practice restrictions and liberation for that? And so there are some things that you need universal mandates, universal approaches to. Otherwise, the actual clinician gets caught in the crosshairs, and then the person who really gets caught in the crosshairs are the patients and the individuals in their communities that would benefit in community centers, schools, and other places where they could really receive care more proactively, I think.
Yes, and we actually heard some of that for those of you who were able to listen to the Future of Nursing report yesterday that was launched from the National Academy of Medicine. Their report, Future of Nursing 2020 to 2030, they hosted a webinar and their report was released yesterday. But one of the things that was highlighted was that really a priority area is removing restrictions and allowing nurses to practice to the full extent of their education and training. And what was highlighted was that in those 8 states that had enacted full practice authority during the pandemic, there were no changes with respect to reports of medical errors or patient injuries. And so it's really highlighting that advanced practice registered nurses provide safe, high quality care and showcasing the benefit of that for patient access, optimal utilization of telehealth, and all the exemplars that we saw, as a result of the pandemic. So I guess the next question is, well, what's next? What's the next steps to really help advance the state of affairs for advanced practice? So Mike, you've had a number of years of experience with respect to Washington's full practice authority. What can you tell us that might be beneficial?
Well, actually, I have some exciting news for you. I watched Tennessee very carefully because my father still lives in Tennessee, and he's told me several times, you need to come back to Tennessee and open your own practice. And I've tried to explain to him exactly, the obstacles for that. However, I would say that I believe in Tennessee and in Kentucky, where I previously practiced, there was a lot of incident to billing. Institutions tend to be risk averse. And when they see the opportunity to share that risk, they tend to institutionally do it. And so I would be surprised if there is not enhanced data about nurse practitioner practice during that month, 3 months period in Tennessee, where
2 months, yeah.
2 months where it was enlarged. I wonder if you may see more data associated with specific nurse practitioners practicing at a wider scope of practice during that time and link that with outcomes. In the advent of great EMRs, I imagine that de-identified data may be available pretty soon from that. I would hope that it is. Now out here, we have seen, I do not see any incident to billing. And it means our nurse practitioners in this state are visible. They're right there in the data, and outcomes can be tracked very carefully. Our challenge during the COVID pandemic the last year has been the financial health of our healthcare organizations. My employer was losing about $2 million a day over a 4 or 5 month period. So my last year has been spent as a locum tenens volunteering, testing centers, that sort of thing, because even our full-time nurse practitioners and some of our physicians could not find enough time to work. We simply, on an outpatient basis, we simply didn't have the opportunities for that to happen. That is, we're recovering from that. However, my clinic here on Bainbridge Island, where I live, is closing on July 2nd. That's our last day. It's been sold, and I won't be working there anymore. So I'll probably have to go across the Sound into the city and work. But this has been an opportunity for institutions to look and see. And to Latanya's point, the features of the organizations, are we as lean as we need to be? Have we offered the widest possible opportunity for our employees to provide the services for which they're licensed? And I know those are questions that are actively being asked at the larger healthcare organizations, probably all of them.
Sure. And the pandemic certainly posed an opportunity for advanced practice registered nurses to showcase the value that they could bring to healthcare. Latonya, certainly, what do you feel is next based on all that you know about advanced practice nurses?
Well, I'm not a good prognosticator. I don't know exactly what's next, but I think I want to make a plug for what could be next. Because I think that sometimes nursing and nursing advocates have been, at this fight for so long that there can be a way of forgetting that in some ways that this fight is in part of a fictional or constructed one. And what I mean by that is that physicians have never been asked to fight for professional authority state by state, insurer by insurer, organization by organization. That's not really a part of their sort of professional path. No one has asked physicians to produce study after study documenting that they're safe in this setting with these patients under these conditions, right? And I think sometimes we forget that. Normally what happens is that someone does the science somewhere, then we do studies to figure out how clinicians can deploy that science, and then we make sure that they're trained to do it, and that's it, right? That's the cycle. And so, while of course there is this battle in which nursing has not been the one to sort of create the terms of that battle, and so obviously by calling it fictional, it's not to dismiss the fact that it's a fight that we had that had to be fought. I think it's important to remember that at a certain point, perhaps not in the beginning, but at a certain point, the terms of this fight really have stopped being about patient safety. They stopped being about evidence, and they turned into something else entirely. And so I think that part of the battle really is to change the conversation, change the terms of the debate, because for some folks there will never be enough data, right? There will never be enough data, there will never be enough status to change the status quo. And so that part of this really is about changing the framing, changing the story, changing the conversation. It really is going to be the sort of next part of that fight. And I think that we saw that during the pandemic, in which so many people suffered, but there were also some places and some folks who made a lot of money, right, at the same time, and these sort of coexist within the same system, right? And so I think part of really, rethinking that framing, rethinking the story, rethinking the conversation really has to sort of start back at how can we achieve good health outcomes? How can we support the sort of growth and health and wealth of our nation? And how is it that all kinds of providers in practicing at the full scope of their practice can help to sort of attain that vision?
Great, thanks for your insights. And lastly, Marilyn, what might be some next steps for hospitals and health systems?
Well, I was inspired yesterday and inspired today listening to colleagues and School of Nursing friends, but I was inspired yesterday by the release of the report of the future of nursing. I mean, you mentioned that, Ruth, and I think that this is a time for advocacy and action again. And I agree with LaTanya. There are data points, and there will be more data points. We need to keep doing that, but I also think that we need to change our focus. And this past 14 months or more, if we have not had an opportunity to look differently at what we can do as nurses, we'll never get a better opportunity. I mean, this was the year of the nurse for a different reason, but it was the year for nursing for the reasons that we all know, that nurses are amazing contributors to the health and the illness care of their communities and the people they serve, and we need to lift that up in every system way that we can, and to really be able to make that difference. So I think it's really a time to lead forward and to talk about that in ways that we can make that difference that we know we should.
Great. Well, thank you so much, and thank you to each of our distinguished panel members for some lively discussions and thoughtful ones as well. We're going to pause for 30 seconds and then hear Katie Page, who will lead a team, who has led a team to secure full practice authority for certified nurse midwives in Virginia. So we're looking to hear her lessons learned as well. So thank you so much.
Good evening. I'm honored to have been invited to give the closing remarks for these presentations, exploring the branding and identity of nurses, and specifically advanced practice nurses in the US. I'd like to share thoughts and experiences on identity and advocacy in midwifery. This series has asked us to think about perception versus reality and the brand of advanced practice nursing. Branding is the emotional experience that's created between a business or entity and their customers. The psychological relationship. How do people experience care with you compared to care with another clinician? Brand identity is what we see, the visual representation or face of the business or entity. How do your clients feel when they see you? For midwives and advanced practice nurses, our brand is directly related to the quality and value of our skills, providing care consistent with our scope and expertise. We embody our brand identity. If we are successful, there can be broad networking and marketing of our brand or brand advocacy through the sharing of stories related to our care, which in this case includes other midwives and advanced practice nurses, our clients, our patients, other clinicians and professionals who work with us. So let's break this down. Advocacy is defined as support for or recommendation of a particular cause or policy. We often think of this in context of legislation. People have expressed to me thoughts and fears of that's not my thing or I'm not good at it. If we consider that advocacy is also our actions in support, defense, or pleading on behalf of others, in the context of healthcare and nursing and midwifery specifically, I would say that this is our thing. We are good at it, and it is fundamental to who we are and our service and work. Being a nurse practitioner, a midwife, a physician is advocacy. In birth work, advocacy is specifically identified as one of the 4 types of labor support that nurses, midwives, and doulas provide, and includes conveying respect, ensuring security, acknowledging the birthing person's expectations, conflict resolution, and partner care. To do this effectively, we need foundational training in school, continuous education from our professional organizations, and cultural transformation of the medical industrial complex so that policies and practices can be grounded in trauma-informed care, implicit bias disruption, and nonviolent communication. To do this kind of advocacy, we have to understand who we are and what we do as the foundation of building or reimagining a brand and what directs our advocacy. How we identify shapes our connections to an issue or a cause, shapes our relation and connection to the people who will be our collaborators or co-conspirators, and with those who antagonize. This is my identity. My name is Katie Page. I am a white cisgender woman. My pronouns are she, her. I am a Texan. I am a mother, a daughter, a sister. I am a wife of a police officer. I am a women's college graduate. I am a child of God. I am an advocate. I am a midwife. I came to Vanderbilt as a bridge student in a dual enrollment program from Randolph-Macon Women's College along a path that I always recognize as my divine calling, like a river that ebbs and flows, and sometimes through rapids or over falls, but always forward moving, guided by the existing land, but free and capable to carve new paths. My education and training in nursing and then midwifery, I recognize as complementary, but not compulsory. It informed and refined my critical thinking and capacity for problem solving that were nurtured in the liberal arts. Though majority midwives in the US receive initial training and identity as nurses, it must be understood that one exists separate from the other. Midwifery is not a role or extension of nursing practice. Nurse midwife is not a type of midwife. It describes a midwife professional trained in 2 complementary fields and philosophies. My examination for certification and scope is identical to one called certified midwife, who is trained solely in midwifery, yet often is identified as a different and lesser type. I deeply value my foundation in nursing and the philosophy of nursing care, yet to advance midwifery in the US, we need to be bold and consistent in declaring our expertise, our identity. Our sacred cow of nurse as the archetype of midwife must be abandoned. For advanced practice nurses, identity and advancement lies in embodiment of an advocacy for how your expertise is unique and adds value to caring for people in our communities, in addition to other caregivers and clinicians. To advocate effectively for the people in the communities where we live and serve, we must be fully engaged in those communities with the people. I live in Virginia, the land where America's colonizers first brought Black midwives as enslaved people. I live in Lynchburg, the ancestral land of the Monacan people. Black grand midwives served in my community before white physicians, building their profession as obstetrician gynecologists, and white public health nurses as midwives collaborated to enact law and policy that would effectively eliminate them from their sacred place as healers. Rich tradition and knowledge have been lost. There's an abundance of healthcare providers, yet lack of access for individuals who are uninsured or underinsured. There are a tapestry of organizations and people who support families of all income levels, and specifically those living in poverty. There are organizations growing or developing to specifically serve the needs of our Black and Brown individuals and families because of historic inequities within our systems and city culture. Yet midwifery remains constant. Traditional midwives have served for decades and continue to train the next generation. Certified professional midwives successfully gained licensure from the state in 2005 through grassroots community support after more than 10 years. The first licensed midwife practices in Lynchburg, and I'm honored to call her a friend and to learn with her continuously and gather in her home with other midwives. Certified nurse midwives have been licensed since 1975 and established within the health system and medical community in Lynchburg since 1985. In 2009, our practice became a midwifery service within a hospital system. And in 2020, we brought a collaborative physician midwife model to a community hospital where midwives provide 24-hour, 5-day labor and birth care with the anticipation of 24/7 coverage by the end of the year. As an aside, when the discussion began on how to improve maternity services at our hospital, one of the physician administrators proposed opening a freestanding birth center with home-based services. So perhaps that's on our horizon as well. I about fell out of my chair when I heard that conversation through the wall. We built relationships with our community midwives for antenatal consultation and to ensure smooth transfer from home to hospital with midwife to midwife transfer. We advocate for inclusion of professional midwives in care planning at the hospital and send records after discharge. Last year, we facilitated their access to our EHR. We advocate for care that supports physiologic labor by changing standing orders to encourage eating and drinking in labor, participation in national and state QI collaboratives to reduce cesarean and treat hypertension and reduce racial disparities. We rewrite policies and support nurse education for labor support and fetal monitoring to standardize intermittent auscultation. We include doulas as members of the care team and partner with local organizations to provide education and peer support for reproductive age people, support training and provision of a living wage for Black doulas to serve Black birthing families. We represent midwifery and advanced practice providers on hospital committees for IT, quality, advanced practice providers, and OB practice. We teach in the PA medicine program and serve as clinical instructors for family medicine residents, PA students, NP students, and student midwives. We are one group of now 14 midwives advocating for person-centered care, trauma-informed care throughout our health system and community. Legislatively, CNMs began to critically examine our practice laws in Virginia when a 2013 change that was developed without our input restricted licensure and practice of nurse practitioners, which included certified nurse midwives and NPs, to in collaboration with a patient care team physician. The Code of Virginia was amended to define collaboration as team-based care led by a physician where only 6 nurse practitioners could be included on the same collaborative practice agreement. This definition of collaboration functioned a lot like supervision, except with a different ratio and a fancier outfit. In 2016, we successfully lobbied to change the language for CNMs to be practiced in consultation with a physician, where consultation was defined as routine or urgent availability based on the needs of the client. What this also did was to distinguish CNM licensure and practice as distinct from NP practice, though we remain licensed as a category of nurse practitioner. In 2017, we met 2 certified midwives who moved to Virginia and began discussions in earnest how to expand licensure. To be successful, we knew we would need education and support of the membership, the Board of Nursing and Medicine, Virginia ACOG, and the General Assembly. It took 2 more years for us to have a serious conversation and planning that culminated with the formation of a task force for the state affiliate, adoption of inclusive language in all materials, bylaws, and our website for CNM/CM, the education for our members and others. We maintained the position that the CM credential is not something new, but the same type of midwife as CNM. Our ultimate success was a combination of years of gradual change, grassroots action, a focused message, resolute leadership, relationships with people in key power positions, and divine timing at a tipping point. The right people at the right time. Nikki's mantra was, "It's already done." And that was so calming the many times that I would frantically message, "Are we sure we don't need to pull the bill?" Or "Are we sure we don't want to talk about negotiation?" Even though the idea of negotiation really was not viable. Our message was simple: Virginia needs midwives. Virginia, like other states, faces a maternal mortality crisis that disproportionately affects women of color, and our maternal and neonatal outcomes for low birth weight, preterm birth, cesarean birth, and breastfeeding were not good. Care by midwives improves these outcomes. Care by Black midwives would help reduce our Black maternal and infant mortality rate and reduce inequities. We met with legislators, our health department leadership, and our OB colleagues a year ahead of any legislation to discuss the intention and receive feedback. The goal was to address concerns and understand opposition prior to filing legislation. Simultaneously, the governor of Virginia was taking up a mantle of improved maternal health care and access and announced a goal to eliminate race-based disparities by 2025. The Office of Health and Human Resources held maternal health listening sessions around the Commonwealth in the fall of 2019. We worked with their office and midwives in communities to include practicing CNMs and CPMs on the panels and in focus groups. We educated HHR staff and community leaders. We shared data from Birthplace Lab that was published in 2018 by Saraswati Vedam and her team that showed state morbidity and mortality related to midwifery integration, referring to licensure, full practice authority, as well as third-party reimbursement. States with higher integration were associated with improved outcomes across all measures. When the pandemic began in March and April of 2020, we were well acquainted with the DHP leadership and were able to join the state task force as we developed and followed the state strategic plan. And we're able to advocate for maternity care and midwifery access in telehealth, PPE resource allocation, and an executive order that removed requirements for licensure that were unrelated to patient safety, which included consultation and collaboration agreements. Executive Order 57 gave us significant leverage to advocate for full practice authority in 2021 with HB 1817. As I hope you can understand, advocacy is not solo work and cannot be accomplished in silo. It requires understanding and engagement of the intersections. It requires relationship. To be effective change agents and advocates, we must be inclusive and bring together coalitions of individual stakeholders. This has been accomplished in Virginia through work that began in earnest in 2015 with a joint statement on maternity care between Virginia ACNM, the Virginia Midwives Alliance, who represent CPMs, and Virginia ACOG. We also developed and held 2 interprofessional collaboration summits in the time before COVID and hope to restart these sessions, which brought together midwives and physicians to discuss team-based collaborative care that emphasized and honored the expertise of each clinician as independent and vital practitioners across all birth settings. In late 2020, we facilitated the formation of a statewide advanced practice provider coalition with representation from leaders of NPs, CNSs, CRNAs, and midwives and PAs, excuse me. Our monthly meetings give us opportunity to understand our similarities and differences, opportunity for collaboration in practice and legislation, all toward a goal of advancing our respective professional capacity to function at the top of our education and certification without restrictions from the medical society. This year, we formed a Midwifery Coalition, which we hope will improve collaboration, relationship, and advancement of midwifery for us all as we look to optimizing midwifery regulation in a work group that was founded from Senate Bill 1320 and House Bill 1953. We've also had success in watching and advocating for legislation related to maternity care, healthcare, employment, housing, firearms, criminal justice, and police reforms, as all of these issues affect the communities we serve in significant ways that intersect with the services we provide. To be sure, the work is not over. Leadership changes within organizations bring opportunities for new relationships to be developed and positions and allegiances to change. Despite relationship building and connection with physician colleagues, we did not receive support from an obstetrician gynecologist, and thus were vigorously opposed by the Medical Society for our autonomous practice bill. Our eventual successful compromise in the Senate for 1,000 hours transition to practice under a physician or midwife was not received favorably by our physician colleagues, but nonetheless achieved its purpose to keep the bill moving forward in a way that we approved and authored and would allow us to achieve our ultimate goal of increasing the number of midwives educated and licensed and the geographic access to midwifery care. Similarly, in our certified midwife licensure bill, compromise was agreed that CMs would be granted licensure under the same consultation restrictions that a CNM currently has. So we also have work to do in the future for full practice authority for certified midwives. 4 of the advanced practice professionals licensed in Virginia, nurse practitioners, certified nurse specialists, PAs, and certified nurse midwives, passed legislation in 2020. Our identity as distinct professionals allowed us to speak truth to our unique specialties, to increase access to care and improve health outcomes. Success for all of us required cohesive collective identity and consistent advocacy. So how will you advocate for the people you serve, the care you give, and the profession you represent? Thank you all so much for attending this evening and for being part of this series.